About 25% of young colorectal cancer now is explained by a hereditary syndrome of some sort. That means the majority are actually not explained by things that we used to hang our hat on and say, oh, you must have something, you have a genetic syndrome, you have something different. That's the scary part, because it's something that's environmental or something else that we can't really explain.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Matthew Kalady. Matt is a world-class colorectal cancer surgeon and director of the Division of Colon and Rectal Surgery here at Ohio State. There's been a rise in recent years in the number of younger patients diagnosed with colorectal cancer, and in response, Matt helped create and lead the new James Early Onset Colorectal Program. Matt will fill us in on the increase in younger patients, the importance of knowing your family history and screening, and all about the Early Onset Colorectal Program. Welcome back to the podcast, Matt.
Thanks, Steve. It's great to be back.
So, younger people getting diagnosed with and unfortunately having bad outcomes from colorectal cancer has been in the news a lot lately. So kind of fill us in on what's going on, maybe some of the numbers and even some ideas about why it's happening.
Sure. And it's tragic, obviously, when you see these kind of stories in the news, but the one good thing is that it brings awareness to what's happening. When you look at the big picture, the rise in colorectal cancer among people less than age 50 has actually been going up over the last several decades to the tune of about 2 to 3% per year in incidence over the last 10 years or so. Contrast that to people older than 50, where the incidence has actually been decreasing about 1%. And we think that maybe because there's more advanced screening, more awareness, and people getting surveyed appropriately and getting treated at earlier stages.
Yes, because if you get a colonoscopy and there's precancerous polyps in your colon, they remove them and you never get cancer.
Absolutely. That's the beauty of colonoscopy. Colonoscopy is one of the really time-tested screening techniques that can prevent cancer from happening. We know that the process from having a normal looking colon to some changes that happen to get these lumps or bumps called polyps, and those polyps then changing further to become cancer, takes about 5 to 7 years, maybe even 10 years. So if you get a colonoscopy at the right intervals, which is about 7 years to 10 years, depending on if it's normal when you have your first one, you can take the polyps off before they become cancer, and that basically gets rid of that risk. And then just stay on top of it. And if they do have a cancer, if it's early, the outcomes are much, much better if you get it early and treat it earlier.
So what is the age now for people without a high risk, sort of the normal family history person, health-wise, that to start colonoscopies?
Sure. So it's important to distinguish between, like you said, average risk and no symptoms, no family history. Just the average population is now age 45. It used to be 50. About 5 years ago, it changed to go down to 45 to kind of in response to some of these increased rates. Then there's also, and we could talk about this whenever you feel like it, the non-average people are people who have either family histories, but people who have symptoms. That's the biggest thing. So people who aren't getting screened before 45 because you're not supposed to, if you have symptoms, that's an evaluation. So it's a little different. It's called a diagnostic colonoscopy because you're trying to diagnose what's the cause of the symptoms, as opposed to a surveillance colonoscopy or a screening colonoscopy.
Well, what would the symptoms be of someone who has some sort of colon or rectal cancer?
The common symptoms are bleeding with your bowel habits or your bowel movements, a change in your bowel habits, meaning the stool is becoming more frequent or they're becoming thinner or you're having trouble getting things out. It might be constipated, could be abdominal pain, could be unexplained weight loss. Then again, importantly too, a lot of patients don't have any symptoms at all. And that's why you need to get screened, because you don't pick it up if you don't get looked at, but you have your regular screening interval, you could pick it up that you know something you don't know that's there.
Now, do you think that the education of primary care physicians they now know about this, and when a patient presents with some of those symptoms that you just mentioned, that years ago in a 30-year-old, they would have never thought colorectal cancer, but now they're learning and being more cautious and recommending screens for people who have these symptoms?
Yeah, I think so. There's across the board, it's not just primary care physicians, anybody in medicine or anybody at all. You should be aware of those things. I do think there's always room to grow, and there's more challenges. We could always refer more people. But it is very uncommon. Say someone comes in who's 25 and they say, oh, I've had some bleeding. Well, the obvious things think, well, it's just hemorrhoids, and don't even think about it.
Right.
But you have to delve in a little bit more. Is there a family history? Maybe you have to examine them to see if there are actually hemorrhoids there. And if that's the case, then you treat them. And if they're not going away after a certain amount of time, then we have to think something different. Maybe they need a colonoscopy, maybe they need some other screening. But you always have to have that in the back of your mind that, hey, this is something more than what we think is just the standard kind of reasons might have bleeding.
Now, family history is vital for reasons you're about to explain to us, including inherited genetic mutations. So fill us in when you or any doctor talks to someone about the family history. What do they need to know, and what will that lead them to either think or do for a patient?
Sure. So it's really important for the patients themselves to know their family history and talk about these things. And sometimes it's a little bit of a taboo. People don't like to, even within families, they don't talk about it. But things that I'm looking for are, is anybody else in your family, particularly a first-degree relative is the most important one. So first-degree relatives are your parents, siblings, and children. So within that core group, your first-degree relatives, if they've got a colorectal cancer in their history, those people, if you've had a first-degree relative, have about a 2 to 4 times more likelihood of having colorectal cancer than the general population. So just having it in your family at all, with or without a hereditary syndrome, makes a big difference. And then in addition to that, we also ask, are there other kind of cancers in your family, not just colorectal? Because there are cancers that run in syndromes, something called Lynch syndrome, which you can talk about, where endometrial cancer is also really prevalent, ovarian cancer, stomach cancer, skin cancers, urology cancers. So if there are other cancers that run in families, we might be able to put that together and say, oh, this looks like a syndrome. You should get tested to see if you're predisposed to getting that.
Genetic testing.
Genetic testing. So genetic testing is, it's basically a blood test or a spit test, and it looks at your DNA. Your DNA is basically the code of everything that happens in your body. Everything from your functions to your eye color to your hair, everything is based on your DNA. And the DNA is the code that makes proteins. You can have abnormalities in the DNA that you're born with that cause changes, and then you get predisposed to getting colorectal cancer. All cancer really happens from mutations or changes that happen in your DNA over time anyway. But if you're born with one, then you've got a much higher rate of cancer and at an earlier age, because you have these changes that are happening and causing the abnormal cells to grow within your body.
So it's vital to know if someone has Lynch syndrome or some sort of genetic mutation, because they're at much higher increased odds of getting that cancer. So what happens? This is a high-risk person. When do they start getting screening, and how often do they get screened?
So it depends on what defines the high risk. So if we want to talk about Lynch syndrome in general, so first of all, Lynch is an hereditary condition that predisposes to colorectal and other cancers. It happens about 1 in every 273 people in the population. So rare, but actually not that rare.
Yeah, that adds up to a lot of people.
So those people can start getting, if you know that they have it, so you can kind of get Lynch different ways. You present with a cancer, and then you get diagnosed with Lynch because you've evaluated for it once you have it. Or say dad has cancer at 45, well, his children may get screened at 20, and they end up having it. So now they have a totally different approach to their screening. They'll get screened at age 20, starting with a colonoscopy, and get a scope maybe every 1 or 2 years, depending on what they find, because they're at much higher risk of getting cancers. The average age of colorectal cancer development is about 66 across the populations. In Lynch syndrome, it's more like 43. So it's a significant shift in that. Early onset in general, we're seeing about 10 to 15% of all colorectal cancer is happening in people less than 50 nowadays. So that's
what you categorize as early onset.
Early onset is less than 50.
So it's that's 16 years less than the average age. So
right.
Okay.
So for Lynch syndrome patients, what we do, the nice thing that we offer at the James is anyone with colorectal cancer who comes in, we give them an opportunity to get genetic testing. And that genetic testing looks at anywhere from 60 to 80 genes that are associated with different types of cancers. So you may not know that you have anything, even if you don't have a really well-defined family history. About 10 to 15% of people will still have some sort of variant on that test that shows that you're predisposed to getting some sort of cancers. So knowing that information is huge for that patient. One, it may determine how we treat that particular cancer, but then also, do we need to screen other organs, like doing a scope to look at their stomach or doing a screen of their uterus? Those kind of things are all important for that person. But then each of their first-degree relatives also have a 50% chance then of also carrying that gene defect, and then they should get tested. And that's what we call previvors. So people who are at risk, but they haven't had a cancer yet. And our goal then is to take them, survey them at the right times before cancers ever develop.
Wow, because I've talked to some people with that. I know one person in particular, he has 3 children. He has Lynch syndrome, and I think one of the 3 had the Lynch syndrome. So that child was getting screened,
Right.
starting I think right then, and the other 2, they didn't have it.
Right.
So, but again, it's each individual child would have 50-50 chance.
Correct. That's just a genetics of it. And if you have it, about 60 to 80% chance in your lifetime that you'll get colorectal cancer.
Wow. So it's vital.
It's there. So that's why if you could get screened and get it before, again, same concept, get them when they're polyps and take them off, you could hopefully prevent a cancer from happening.
That's the colonoscopies are amazing, and they prevent cancer. So now I've also heard that because people, younger people don't get screened, they often present with later stage colorectal cancer, where a comprehensive cancer center and a dedicated cancer hospital like the James comes in, because you are a world-class colorectal surgeon. So unfortunately, you don't want to, but you probably see a lot of younger people with some later stage colorectal cancer that requires some pretty complicated surgery.
Right. And unfortunately, that's true. The colorectal cancer is a team sport in a lot of ways, though. So I'm the surgeon. We have a radiation oncologist, we have a medical oncologist, we have genetic counselors, we've got social workers, all types of gastroenterology physicians, all types of people are part of the team. The main treatments really stem down to surgery, chemotherapy, and radiation. So getting that team together is really, really critical, and that's what we have here.
That's why you want a comprehensive cancer center,
exactly,
hospital like the James.
Right. So unfortunately, as people who are younger do often ignore symptoms, they do present at later stages, like you said. People with stage 3 and stage 4 really require that multidisciplinary care, where you're getting all the different kinds of treatment together, because we know that the teamwork and getting those different treatments improves your outcomes.
Where does it spread to? Is there specific places that it usually goes to?
Yes. So it usually starts in the lymph nodes around the colon or rectum, wherever that regular lymph node drainage is. And lymph nodes are just kind of a clearinghouse system sitting in the fat around the bowel. So as blood and lymph circulate through your body and around that tumor area, it kind of clears through those areas. So it goes to lymph nodes first, and then it'll go to other parts of your body. The most common ones are being the liver and the lungs.
Okay, I think I've heard that. And that's because of proximity and just where the lymph nodes sort of drain to?
It has the lymph node drainage and the blood supply, so it will travel through the blood. It could travel through the body either through the lymph system or through your vascular system.
So that was a great sort of overview on what's going on. Do you know why? Why are younger people getting colorectal cancer at a higher rate?
It's a great question. We have some insights and thoughts and research is constantly going on about this, but we don't know exactly why. Just to put it in perspective too, if you were born in the 1990s versus the 1950s, you're 2 times more likely to develop colon cancer in your lifetime and 4 times more likely to develop rectal cancer in your lifetime.
Wow.
So there's that time shift. There's something in a birth cohort, they call it. So over time, if you're born in a certain time age or time frame, you're at much more increased risk. That being said, we think that there's something probably in the environment that's changing, something in lifestyle. It could be processed foods or ultra-processed foods, more sedentary lifestyle, certain dietary things, so a lot more processed red meat, high-fat foods, less fruits and vegetables. All those things kind of combined are hitting people now. So I think there's environmental exposures that weren't around in the 1950s that are now around here. And as I said, it takes probably 20 years for changes to actually happen to become a cancer. So these earlier exposures in childhood or in early adulthood are happening that weren't happening 40, 50 years ago. And now you're seeing this, people in their 20s, 30s, 40s getting cancer.
Now, when you say environmental factors, are you talking primarily about food and processed food, or is it also what's in the air and water and ground?
It could be any of that. So there's obviously some thought about microplastics and some of the things because microplastics are everywhere. It's what we drink, what we eat. The big thing, which probably in my mind has a big push, is the microbiome, or what the bacteria is in your body. So your entire body is colonized with bacteria, millions of bacteria, and a lot of that's in your gut. It's just that it's our interaction between the external world and our internal world is the microbiome. And what we eat, what we drink, what we smoke, what we inhale is all impacting your microbiome. The balance of your
That's the
system in there.
billions of bacteria
Right.
in your stomach.
Right. In the stomach and the colon, it goes all the way down your entire GI tract. There's a healthy combination, a healthy balance between those things. But if something goes awry or something changes, we know that certain bacteria can secrete proteins or toxins or other things that might lead to developing colorectal cancer.
So it sounds like you know that's a factor, but the research is still in the early stages about how to, what is the perfect perfect what you want and how to get there.
Right. And there's definitely some research is a little bit further along, but we still don't know direct causality. We still don't know how to intervene. There's all types of ideas say, okay, if we did an antibiotic or maybe a probiotic to change that balance, it could be helpful, but we don't know what that is just yet.
Right. What is the right balance? That's what science takes a long time.
Right.
So all these factors, you decided as part of a much bigger colorectal program, you're going to focus as one of your areas on early onset patients care and research. So fill us in on where the idea came from and how it kind of fits into your overall colorectal program.
Sure. So we developed the James Colorectal Cancer Center a few years ago. And the idea for that was really to improve patient outcomes and improve patient experience and everything about patient care. So it's really a comprehensive longitudinal approach to patient's experience. So within the Colorectal Cancer Center, we have 5 main pillars. And that was on things that we think are kind of the things that really make a difference. And some of them may be more complex or rare types of disease or sections within colorectal cancer. One of those is early onset colorectal cancer. One's rectal cancer, because rectal cancer particularly has the multidisciplinary care we talked about. Advanced disease or metastatic disease, where it's going to liver or lungs. And again, we have multiple teams together to do that, try to improve outcomes. Hereditary colorectal cancers, which you talked about, and that's a subspecialty in itself. And then anal cancer screening and trying to help some of the underserved people who are more prone to getting some of those things. So those are 5 main pillars. We chose early onset as one of those pillars because we were seeing a lot more cases. Nationally, we know the trends, and in our own practice, we're seeing it all the time. We see it in Columbus. And every one of my clinics, I see somebody who's less than 45, even younger, who has colorectal cancer as a new diagnosis, or they had no idea.
When you say clinic, I'm not sure if it's once or twice a week, you see patients.
Yes.
And that's called
Right.
clinic. Yeah.
So we'll see patients in the outpatient in the office, and that's where people with new diagnoses or getting talks about before surgery, getting followed after surgery, getting followed for cancer surveillance afterwards, all get seen in our outpatient clinic.
I mean, you've been doing this 20 plus years, and you say you have noticed that you're seeing younger patients regularly.
Absolutely. So because my practice has been a lot of hereditary cancers, I've seen young patients throughout my entire career.
Okay, because you always, okay.
But I've seen a lot more of unexplained, so to speak. So not the hereditary syndromes. And also being a big referral center, we do get the hereditary cancers, and then we get people who are younger, because not everyone, when someone from the outside sees this, so this is odd, this is strange to see a 35-year-old with cancer, they should probably go to a specialized center. So as a referral center, we get a lot of those cases.
And you also probably get people who need more complex treatment because
Absolutely.
You guys are the best.
Right. And we look at things, it's about 25% of young colorectal cancer now is explained by a hereditary syndrome of some sort. That means the majority are actually not explained by things that we used to hang our hat on and say, oh, you must have something, you have a genetic syndrome, you have something different. That's the scary part, because it's something that's environmental or something else that we can't really explain.
So what are the elements that make up the early onset program? And perhaps I'm thinking younger people have different needs than older people.
Absolutely. So we offer the same sort of services to everybody with colorectal cancer, but there are some special needs within the early onset group. These, unfortunately, people are at the kind of peak of their lives, a lot in professionally and personal lives. They could be in their 30s and 40s. You might still have young children, maybe just bought a new house.
They may want to have children.
Right. And want to have children. That's another big part of that, which we could talk about. And you're really just kicking on all cylinders probably at this point, and you haven't necessarily saved a whole lot yet. You're maybe at the highest earning potential, all those things. And all of a sudden this kind of curveball comes at you, and it stops everything you're doing and makes you think about things. So we do offer, first of all, within the clinical care realm, we have all the services available to them. We have comprehensive kind of longitudinal care where people will see all the specialists they need to see. So the idea is trying to make sure they're getting the best outcome, so to speak, first of all. They get genetic testing to make sure they're in a syndrome or not, and how that may influence their care.
Every younger patient gets genetic testing.
We offer it to everybody, regardless of age, but we really try to push it specifically for younger patients too, if they don't want to kind of explain the importance of doing all that stuff. But then there's the social aspects of it as well. So there's social work, there's financial counseling, there's fertility preservation consultations, support networks, advocacy groups, all those things that people need to know about that's going on specific at that point in their lives.
What about colorectal cancer would impact fertility for a man or a woman?
So mostly it's for rectal cancer, some with colon cancer, but rectal cancer is down in the pelvis. That's around where all the reproductive organs are. Rectal cancer that's more advanced, not even that advanced, but stage 2 or 3, gets radiation as one of the primary treatments, and radiation will cause sterility by itself. Chemotherapy by itself also can cause sterility too, or have trouble having children. So if you know that you want to have children afterwards, there are programs where you can do sperm banking for males and then egg preservation for females. There's also programs where the ovaries, which are obviously the things that produce the eggs and for fertility, you can have them and actually try to pull them out of the pelvis, and what we call pexing, or tying them up out of the pelvis and sew them to the abdominal wall, so that when you get radiation, those ovaries aren't affected by the treatment.
Wow, that's fascinating. You move them, the radiation is given, and then when the radiation's done, they're moved back?
They can just stay there.
They
can stay where they are.
Because no need for a separate procedure if it's not necessary.
Right.
Wow. See, again, it's always amazing the number of different people and experts and procedures and things that a comprehensive cancer center can do for a patient. And that was just a perfect example of that.
Yep.
Wow. Well, we're going to take a quick break, and when we come back, Matt will fill us in on some of the research he and his team are doing into early onset colorectal cancer.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Matt, and before we dive into some of the interesting research you and your team here are doing, I was just thinking, what's an example of a younger patient that you treated who had an interesting case and hopefully a good outcome?
So as I said, we're seeing more and more people in their 30s, definitely 40s, 30s, and even in their 20s. I'm giving you one case, which was a great pickup finally by the primary care physician, was a younger man, he's in early 30s or so, who was very active, very fit, never had any health problems, but he was having some bleeding with his bowel movements. He was at the gym all the time, and they just kind of blew it off and said, well, it's probably just straining, you got hemorrhoids. But they didn't go away, and after a couple months, he finally said, I really need to get this looked at, and they got sent to the colorectal surgery, or sent to gastroenterology to get a colonoscopy. Turns out he has a rectal cancer. So he got sent into our clinic at the Comprehensive Cancer Center. We picked it up. It was still fairly early stage cancer, and we were able to treat it successfully. He ended up having surgery. It was totally removed, and now he's living a good, healthy life all the way through.
Wow, it's just the importance of early diagnosis cannot be overstated.
Cannot.
Wow. So that brings us to research, and this is where I'm always fascinated by all the new ideas and things that are going on. So what are you doing?
So again, we have a whole team of people doing this. There's a lot of focus here. People are interested and kind of passionate about looking at these cases. There's always clinical trials. So we're doing clinical trials across colorectal cancers, both with radiation and chemotherapy and new regimens with that. It's not necessarily unique to early onset patients, but I think it's really important to enroll that subpopulation of patients into these trials, because if you want to have something that's effective across the entire population, or say we're going to do something that's effective in younger patients, we have to include them in the trial. You can't just treat all 60-year-olds and then try to extrapolate that out and say it's going to work also for those patients.
See, I've heard that with other cancers. In clinical trials traditionally have been older people and maybe not as diverse a population as you would like. And so it's important to get people of all ages and diverse populations, because everyone gets cancer.
Absolutely. So we got to be able to apply the results to the population that we're trying to treat. So that in itself, we're very cognizant of trying to get the younger people into the trials that we always have up and running.
Are they receptive?
They are. A lot of people are. I mean, I think there's a lot going on in their lives, and sometimes just throwing an extra trial in is a little maybe too much for them to handle. But I think a lot of the people that I've experienced, at least, are very interested in trying to, what's the next best and greatest treatment to go with, and they're pretty receptive.
What are an example or two of some of these trials?
Some of them are unfortunately for more advanced disease, but we're looking at different forms of radiation. So just to take a step back, people with stage 2 or 3 rectal cancer will get treated up front with what we call neoadjuvant therapy. And that's instead of going to surgery first, they get treated with chemotherapy and radiation. And then afterwards, we take a look and see what kind of response they've had. And if they still have residual tumor, they'll go on to surgery. If they don't, there's actually a subset of people that have a great response and we don't do surgery at all. So we try to figure out how can we increase the effectiveness of chemoradiation to get people more to the point where they don't need surgery or have a better response. So there are different radiation sensitizers that we're treating, and also different sequences of chemotherapy and styles of chemotherapy that we use with the radiation to try to make that whole neoadjuvant therapy work better.
Because I'm guessing that chemotherapy is getting better and more effective, and I know radiation is getting more precise and effective. So that combination, is that what's allowing sort of this to happen, that you can do more before surgery or eliminate surgery?
So it's really been using the combination of chemotherapy with radiation up front. Traditionally, even 5-10 years ago, we would do chemoradiation, so radiation mostly with a little bit of chemotherapy to sensitize or make the radiation work better, then surgery, then chemotherapy. We found that a lot of people weren't getting the chemotherapy after surgery for various reasons. They were debilitated, they were tired, they were sick, they didn't tolerate all of that. So, and then although people were getting treated of their primary tumor, they might be having a higher rate of dying from distant disease. So the thought was if you could take chemotherapy up front, before that, you'd have a higher compliance rate and people would complete their therapies. And it actually turns out you do have a better outcome in overall survival if you do the chemotherapy up front. So that was the push to do it that way. And now we figure out within that regimen, how do we make that work a little bit better? The other big thing that's happened in the last couple of years is the kind of boom of immunotherapy. So tumors are seen as foreign, and some of them are more immunogenic than others, meaning that your body recognizes them and will attack them. There are certain tumors that are highly immunogenic or really makes them susceptible to getting immune therapy. Unfortunately, with colorectal cancer, it's not a huge percentage, but with a certain percentage of rectal cancers, about 5%, are a certain tumor type called microsatellite unstable or mismatch repair deficient, which is kind of fancy terms for saying certain things don't work. But because of those, they're highly immunogenic, and immune therapy works really, very well in those patients. For rectal cancers, when we give immunotherapy up front, more than 95% of them don't ever need surgery because it's completely gone.
Wow.
So that's a huge advance in some of these things. But it's only a small subset of the population right now.
Are new drugs being developed that will increase that subset of the population that it will be more effective for?
So and this is tied in a little bit to early onset, because some of the people who have hereditary syndrome or have the microsatellite unstable, this type of tumor. So the research we're trying to do is, can you take what we call an immune cold tumor, not something that draws a lot of the immune response, and somehow make it hot? So can you change the characteristics of the tumor so that the body recognizes it as more foreign and has a lot more reaction to it? So something that doesn't necessarily respond to immunotherapy, how do you make it responsive to immunotherapy?
So the cancer tumor is hiding, and you pull away that
a little bit
cover. That's
yeah.
hiding.
So the tumor, the normal machinery of the cells kind of churn out and break down stuff, and then they put some of the breakdown products of the tumor onto the cell, the surface of the cell. And then as that cell gets recognized by your immune system, as it circulates through, it says, oh, that's not normal, let's kill it. But the tumor does hide. It doesn't put those things on the cell. So how do we make the tumor put more things on the cell that's going to be recognized, so to speak?
Oh, and there's ways to make the cancer tumor, put more.
Theoretically, we're trying to figure some of that stuff out. Right.
Wow. That's amazing. Anything else you're doing in terms of research?
Well, there's some things that we're doing within our program is just gathering information. So we know we're trying to gather for people that are younger and people that are older. So we have comparison sets. What do they eat? What's their lifestyle like? What's their activity? What do they do? Some epidemiologic kind of criteria, what's going on with them. But then we want to gather the genetic kind of components of things. So all their tumor. So can we get a piece of their tumor? We get a piece of their normal colon. We get blood, and we get stool samples from everyone who comes in with colorectal cancer, particularly for the younger patients. The idea being, same things we talked about, we could study what the microbiome looks like in their stool. What kind of bacteria do they have? Are there markers in the blood that are different, inflammatory markers in the blood? Is the cancer different than normal, more so than the cancer different than normal in older patients? So as we collect all this information and we get a core of 50 samples, 100 samples, we'll be able to then do broad scale analysis of all those things. It's a little bit of a, I'm going to call it fishing expedition, but it's more of a guided exploration of what might be different in those patients. And can we use that information then to identify new drugs, new targets, new markers, to pick up early detection?
So you're in the early stages of this, it sounds like?
We've been collecting samples for about 6 months now and building on that.
Wow, that's interesting. Will you be using AI to help you analyze them?
Eventually. So there's different ways of looking at the biostatistics of it and analyzing all the different things, but I'm sure there's programs for AI that'll help us do that.
Wow, this is interesting because epidemiology is so important, and you're using that plus genetics and all these other things to come up with what is different or what's the same and how
Right.
and in these younger and older people.
Ideally, we'd like to identify the people that are highest risk, and we know that's not always family history. So the people who are
Right, you said 75% is not
Right.
related to
and the people who are less than 45 aren't getting screened,
Yeah.
but we know they're out there who are at risk. So is there something that we could pick up in a blood test, in an epidemiology marker, in an AI screen that we identify, oh, if you're in your 20s and you have these things, you're more likely to get colorectal cancer, so you should get screened. So we can't screen everybody. We just don't have the resources or the money to do that. But if we picked up the people who are at highest risk, they should get screened and hopefully prevent it. So we got to identify who's the highest risk.
So if you're able to do that from someone's blood, does that mean that someone who's 25 that goes into their yearly exam and gets blood drawn for cholesterol and things like that will also be looking? They'll also be looking for.
I think that's the future. There are definitely some tests out there right now that are what we call pan cancer, so blood tests that maybe pick up if you got cancer, any type of cancer. So that's the future.
That is the future. That
absolutely.
a simple blood draw is going to be able to detect all kinds of cancers and other diseases way before their symptoms.
That's the hope.
Well, Matt, thank you. That was really interesting and important. My takeaways are know your family history, talk to your primary care physician, screen as soon as you can at 45. If you have any symptoms, really be an advocate for yourself.
Absolutely. And don't ignore symptoms.
Yeah, don't ignore
I always tell people too that no amount of bleeding is normal.
And
there's got to be some cause of it.
And people are embarrassed about that, and I have a feeling that prevents them from often talking about it.
It does. There's definitely a stigma about people don't like to talk about bowel habits or anything abnormal down there. So it's important to get over that because it can save your life.
Wow. So you've been here 5 or 6 years. You've built one of the best colorectal programs in the country. You're starting an early onset program. What motivates you to do all this, to go above and beyond for your patients, to create new programs to help lead research?
Well, I like to think I'm the luckiest guy in the world and that I love what I do. I love my job. I like the science behind it. I love talking to people, and I like being able to make a difference in their lives. So these are patients that you're seeing that are sometimes at the lowest point and are scared. They're nervous. They just got a new diagnosis. To be able to intervene at that point and improve their life and hopefully save their life is extremely motivating to me. And when I look at it, the experience can be better. It's not just, you don't just go in and try to fix it, but how do you make the patients comfortable? How do you make them confident that they're getting the right care and then they are getting the right care? So it's how do you design a bigger picture program? That's where I think the idea of the Colorectal Cancer Center kind of came from. Longitudinal, comprehensive, complete, multidisciplinary, make sure everyone's getting it. And I can see myself and my family and other people in every patient that I treat. So I always think treat them like you would want to be treated or want your family member to be treated. So unfortunately, both my parents have had cancer, or I lost my dad to cancer, and I've seen his whole journey, and I think the outcomes could be better, the process could be better, and the care experience can be better. So that's what I think kind of drives the day-to-day work.
Wow. Well, I'm sorry to hear about your dad, and sure that you honor him by the work you do.
Thank you.
And thank you for filling us in on everything you do.
Great. Thanks, Steve.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.